This is a session on precision oncology, and we're going to talk about the care delivery and the practice management. Now, how many of you, raise your hands, how many of you are familiar with precision oncology? Only one person? Nobody else knows anything about precision oncology? Do you know the spelling of precision oncology? Okay, so who, how, what, when, and when not. The important thing is the when not. And precision oncology is defined as molecular profiling of tumors to identify targetable alterations. You know, it was Ehrlich about 100 years back who first defined the magic bullet. And that was what was the beginning of targeted oncology. In 1977, estrogen receptor was discovered, the BRCA in 2001, the KIT-HER in 2006, the ALK, BRAF, and JAK2 in 2008, the BRCA in 2011, ROS1 in 2014, FLT3, IDH2, and MSI high and DMMR in 2017, the NTRK1, IDH1 in 2018, the PIK3CA and FGFR3 and 2 in 2019, the PDGFR MET exon 14 RET in 2020, and then the KRAS 12CG and the NRG1. This has been the evolution of mutations and methods. The immunohistochemistry was started first, and then it went on to FISH, and then the PCR. The first routine use of EGFR mutations was done by PCR. There's actionable activating targets, there's actionable resistance targets, and there's actionable targets in development. Next slide. There are 14 of these various hallmarks of cancer. These include, well, you can read them, I'm sure, in all these things. For constraint of time, I think we should start. Let me invite Dr. Kumar Prabhash. How many of you know him? That's all? Well, Kumar needs no introduction. He's the professor and head of medical oncology of solid tumors at the Tata Memorial Hospital, and is got his special interest in lung cancers and in head and neck cancers. He's going to talk this evening on advancing comprehensive liquid biopsies in non-small cell lung cancer, insights from the Indian patient data. Now that's the important thing, the Indian patient data. That's what he's going to present to us. Let me also invite, you have to speak. Yeah, sorry, my apologies. Before I have Dr. Kumar, let me invite Dr. Gowhar. Dr. Gowhar is from the OneCell Diagnostics, and he's going to give you a prelude to the presentation. Dr. Gowhar, please. I don't know how many of you know Dr. Gowhar, but he's one of the very fine young molecular geneticists, and he has worked in the Karolinska Institute. He has worked with Nobel Prize winners, and believe me, one of these days he's going to get the Nobel Prize too. So may I introduce Dr. Gowhar Shafi.
Thank you, sir. So, I'll quickly talk about comprehensive genomic profiling. What is comprehensive genomic profiling and how our comprehensive genomic profiling called OncoIndx is different from the available in the market. So, when a patient comes to an oncologist, particularly, in late stage in India, what we see is most of the cancers come in late stage, already having multiple metastases. And the urgent clinical question, which is very much important to assistant oncologists, is, disease is progressing. Why it is progressing, despite you might have done earlier a single gene test and using a targetable drug for that targetable mutation is progressing. Can the treatment be personalized? If disease is progressing on the targetable mutation, what can be done? Can we add another molecule, make it a combinational therapy? Can we identify what is the toxicity profile for that patient? It's very important. We were just listening in the previous discussion. It becomes very much important to understand, what are the different therapeutic options available for a patient, and how can we understand what are the toxicities associated with these therapeutic molecules, particularly when we are combining multiple molecules. And that's what is pharmacogenomics and pharmacodynamics. And this is most of the panels available in the market, they ignore it. It becomes very important. And one more important thing is, when we talk about comprehensive genomic profiling, so it is not just, number of genes which we have to profile. It is which can give us a complete picture, what we have to treat the patient and what not to treat. So what is important now in today's literature, if we look at, there are more than 350 genes which are involved in various resistant molecular pathways for all those actionable molecules which are available, be it a small molecule or monoclonal antibody. And therefore, it becomes important for us to understand the resistant mechanism before we start the treatment. And then can we identify, metastatic potential of that patient, if it is the early stage? If there is a possibility of metastatic potential, and which patient will progress, and how can we personalize the treatment for that patient? Most importantly, now it has become very important, even those indications where we do the surgeries, and can we identify minimal residual disease, and can we decide which patient will need adjuvant treatment, and in advanced setting, can we use in this molecular profiling to monitor the therapy response? So this all keeping in mind, that's how carefully we have designed OncoIndx panel to make sure that we address all these issues which an oncologist is thinking when patient comes to him. And we know that, based on this, we have decided there are the 4 pillars of this comprehensive genomic profiling, and it has to be in the CGP. Then it's called CGP. So first is, it should not be, ready-made what is available in the market and just buy it and start running in the tail. We have to customize it because we talk about personalized treatment. Therefore, we have to customize the panel itself, what has to go be in the panel, how we design, how we select the genes, how we select the gene regions, and how many probes, to increase the sensitivity, etc. And then, how to optimize that. It's not one-day job. It's continuously evolving process where we keep optimizing the whole process. And more importantly, when we do these genomics, it produces tons of the data. And these data, we cannot open in normal computers. We need, high performance computers or cloud-based computation. And how we do the bioinformatic analysis, we have to have an enhanced bioinformatic analysis. What we use is like artificial-based bioinformatic analysis, which increases the sensitivity and specificity. And more importantly, when we are talking about these assays, they have to be validated, both technical and clinical validation. And how these are important, this helps us to improve the quality, improve the turnaround time, improve the cost, decrease the cost, and then most importantly, in interpretation is the big issue, and that's how we address this. This is what quickly I will talk about that. How the customizing the comprehensive panel is helping us is, if we look at that, cancer is we are continuously evolving, understanding. Just now we heard about the hallmarks of cancer. In 2002, there were only 4 hallmarks of cancer. And today we have 14 hallmarks of cancer. That itself explains cancer is becoming more and more complex. Therefore, we have to have a comprehensive large panels to understand the cancer biology before we start treating. And more importantly, we need to do a lot more research on Indian data. We completely depend on the Western data, but we need to show our own data. So to help in order to, make it better for our patients. So OncoIndx, it's a comprehensive panel, about 1,080 genes. It's not a number here. Again, I'm telling you, it's how we can identify which therapy will work, which therapy will not work. But technically, when we talk about, what is the number of genes, how many exons, what are the biomarkers we cover, is whether it's in small insertion, deletions, copy number variations, fusions, tumor mutation burden, MSI, loss of heterozygosity genome-wide, whether it's in specific gene or in HRD, all that is covered in one single assay. And more importantly, in a previous discussion, we were talking about, panel discussion, they were talking about that drug metabolism, pharmacokinetics, pharmacodynamics, those markers are the part of this panel. That makes a big difference here. And, the other part of that, optimization, technical optimization, bioinformatics analysis and validation, how it is helping us, this is the panel, where we have done the validation and be it a, single nucleotide variant or, SNVs, indels, fusions, where we have that detection limit, less than 1, it's 0.1%. And you can see the sensitivity and specificity of the assay, and that increase the confidence. It's very important in a clinical setup. And to, at last, it becomes very important when we generate the data, we need the tools which does that data analysis, provide us the actionable information. AI-based tools are used. We have a tool called iCare, which helps us to understand this, data much better, particularly for clinicians providing live dynamic reports, which means if I have provided a recommendation, what is the source behind that? What are the clinical trials going behind that? And, if there is sometimes we find it's a mutation, maybe BRCA mutation, lung cancer, and then often is it possible? Have anybody seen that mutation in lung cancer, and how is it relevant? That all provides by dynamic reporting. With that, I thank you.
So, good evening, everyone, and my job is to present data regarding one of the work which we did, a collaborative work with OneCell, and it is a developing data, but we'll be sharing with you till what has been done, and it is an interesting one. So what we did was, this was the problem statement, that we know that we want to have molecular testing. Tissue is always preferred. Liquid biopsy remains the stepson because of various issues, and there are issues. It's not like it is without a reason. But looks like as the time has gone by, slowly it has become a good complementary test. Now, we are trying to see that where one can put this as a clinical utility in the testing for as far as the lung cancer is concerned. We want to do many more, but that was the first issue was in lung cancer. Now, this is the mutational landscape in lung cancer. We have our own. At the baseline, by and large, it is agreeable that you have a fairly good concordance. You lose 20% of those mutations, which is diagnosed by tissue if you do only liquid. And you add 5-7% extra if you do liquid, which you are missed by tissue. So in bargain, what happens that you lose more by liquid than by tissue. But remember, if you do both, you do add some more. And there has been lots of discussion that are we going to advocate that we need to do both? I'm not saying that you need to do both from tomorrow, but you'll be hearing about this more and more as the time goes by. And Natasha Legil paper suggests that you do pick up, and surprising part is that when you pick up, they are not that you pick up some unknowns or unknown mutations, so rares of the mutation. Here the common mutations like EGFR ALK somehow looks like you do get missed in tissue and you do get pick up in liquid biopsy more. But again, remember, I put the number at 5-7% more. But again, I repeat, you do lose 20% when you do only liquid. Now, as I said, as a clinician, you always have the idea that how it is, useful for my patient. You may have the test. That is, for example, I always say, if any of my student is around, I say, hey, I have to go home. Rocket is a better technology than a car. But I don't take a rocket to go to home. I take a car to take a home, unless someone proves or it becomes more useful for me to use rocket, and sure, I'll be using rocket tomorrow, but that utility has to be there for any technology in the clinic. And here, for medicine part, it remains how it is useful for my patient. And that is what we keep discussing for liquid biopsy. And that was our discussion in our group when we had this discussion, and also with the scientists from the OneCell. So this is, we had some of those samples available, and this was a part of the study which was there, the patients who we had given some chemotherapy with TKI versus only TKI, and that was a randomized trial. We have a JCO publication. So we had a clinical data, and we had a whole lot of blood samples which were available, and we are trying to make what we can do out of this. The first part we did was that was the easy one, because PCR is available, not at very costly, it's not a very costly affair. So one of our PhD students did say, hey, you do a COBAS-based test, PCR, at the baseline, and then see, after 2 to 3 months, and then see that if the clearance has a bearing on as the outcome is concerned. So what you see here, the median PFS, EGFR positive and EGFR negative means what? In case they were positive at 2 to 4 months, what was the median PFS? Around 8 months. If not, it is around 14 months. And the OS similar, suggesting that if you have, based on the COBAS kit, which is not very sensitive kit, for detecting the minimal residual disease, meaning that it misses many of them. When you want to pick up minimal residual disease, what do you want? You want whatever is there. Can I pick up the slightest hint of the tumor being there in the body? That's what you want to do. But that time, this was what was available to us, and it showed that yes, it makes sense that if you're able to pick up, that minimal residual disease is there or not based on PCR, the curves does separate. But this is also true. Again, this is a good paper. Paper was in clinical lung cancer. It was a part of my PhD thesis of my student. And I see Dr. Anuradha madam here. She was one of the person who worked on it. But sure, it looks exciting that there is a merit in this concept. But clinical utility is a question. That it doesn't separate so much. Both keeps falling. They fall fairly close to each other, but they do separate, giving a hint that yes, this concept has a merit. What it means, if you pick up by a more sensitive technology, more positive patients, meaning that you pick up more pure patients, which are real negatives, there is a chance that you may have wider separation of the curve. And if there is a wider separation of the curve, then we do know the clinical utility increases. So after seeing this paper, we were keen on addressing a project and trying to see that where we intensify, where we de-intensify. But somehow the clinical utility was an issue, and we didn't move forward with the project. Because that difference, what I showed, looks, we have Dr. Raja sir is there. It is useful, but not something which we are willing to de-intensify. So again, there was an issue. And that is why this project. So we thought, can we do comprehensive genomic profiling? And with a sensitive technology like NGS, and then find out, does it help our patient? And what are we doing? We are extending the phenomenon which we are doing. So we say, hey, you picked up with liquid biopsy, PCR based, have a more sensitive technology. All those negatives, you pick up more positive out of it. You leave those negatives, which are the real negatives, and then maybe you start picking up those good ones separate and the bad ones separate. So CGP to guide better treatment options. That's not what we did, but that is something which we want to do in future. CGP predicting better clinical outcome. Yes, that was definitely the goal. Smaller panel, few actionable insights are there. That is, that was a trade between us and OneCell, because they have a wider panel. Say, okay, fine, please choose whichever you want, whatever number of genes are there, we are okay with it. We are okay with limited panel also, but we don't get into that. We want to have an question to be answered. Whichever way it gets answer, we are happy about it. But I do concede more is better if the cost is lesser. But having said that, we were answering a question, so we were okay with till the cost was taken care by the OneCell. What it provides, actionable insight, that is true. Resistance mechanism, which kind of those mechanisms we have. And this is what you get out of this when you do this whole work, because the moment you have 1,000 odd genes, you get all kind of things. You will get TMB, you get MSI, which you get HRD, which you get LOH, and this we are going to get in lung cancer. But that was the incentive for me. So I was trying to get data regarding only having MRD being there or not. But the advantage for me was, because Arvinder and Jayant wanted to have 1,000 panels. So we say, hey, there is a merit to having more data. So what was the objective? To find out EGFR variant dynamics. We'll come to that why we're saying dynamics, because here we had 75 patients with 600 odd samples. So what it means, we had a sequential samples for many patients, and many patients had 20 odd samples. So we had many more things can be done. Right now we'll show you some glimpse of what we have. So you have what is happening to the patient as the time goes by. Clinical responder versus non-responder. We had a definition of that 6 months and earlier. If they had progressive disease, we called it non-responder, and beyond that we called it responder. Is arbitrary, I do concede, but having said that, we wanted to have some extreme of patient and trying to see that can the dynamics predict who will do in which way, and the survival outcome. How do we go beyond EGFR and other NCCN gene? That was another factor, but unfortunately we don't have drugs, Arvindan. So otherwise, it is a good goal, but maybe we need to partner with some other people to predict PFS and OS at the baseline with the resistance signature obtained from the CGP. Does the baseline predicts what is the PFS and OS? Do determine the role of CGP as a prognostic factor in early progression and poor outcome. Means similar, but a bit difference for lab part of it, but for a clinician means similar. Dynamic changes in the outcome, dynamic changes in the in the molecular signature, and genome-wide instability signature like MSI, TMB, HRD, LOH score, and TF, that is a tumor fraction, and its correlation with the clinical outcome. This was a 75 patient sample, 545, as good as you get. You don't get many studies. I'll tell you the only problem with the study is that you have a 75 patient and you have a 600 odd samples of a number. Usually don't get in liquid biopsy. You have those gefitinib plus chemotherapy, and then you have a data where you have an outcome data for each patient. The only problem is gefitinib trial. I wish it was osimertinib, and I did say that. That doesn't mean, but in gefitinib trial also you won't get this number of samples where the analysis has been done and where you have a sequential data. Now let's see what is the outcome. If you see the multivariate analysis, it appears that if you do have resistant mutation, and remember resistant mutation has been defined, that is ERBB mutation, resistant TKI, tyrosine kinase mutation, and then you have a EGFR signaling mutations, which were clubbed at that these are resistant mutations if they are present. If you have two or more than two, or any one, it looks like it's bad. The outcome is not good for the patient. Tumor fraction high, again looks like the patients, they don't do well. And then it looks like it gives a hint that if VAF is more, TMB score is high, HRD score is high, then looks like there's a trend that patient doesn't do so well. Now let's go back to how we derive to each of them and how the data looks like as far as the curve is concerned. Now, this curve is striking, and this is what we have been hoping for, that you get a marker or group of marker, and what we have a group of marker, that is if you have a resistance signature in these patients at the first sample which was analyzed, as compared to a sample where you don't have it, it appears that patient does very differently. And this is based on liquid biopsy testing, suggesting that if you don't have it, very few patient fails. If you have it, then majority fails and the curve drops strikingly. Overall survival looks like if you don't have it, those resistant mutations in those liquid biopsy, at the first sample what you get, by and large, most of the patient keeps surviving. And if you do have it, again, it looks like it falls pretty sharply. And that gives a good hint, and that is what we were looking for, and which I was saying, PCR gave us a hint that it happens. Here it gives that, yes, looks like there is something which we will like to take in the clinic, meaning that we will like to intervene based on this. And as Dr. Raja said, I was suggesting that most likely we won't. Here, maybe we'll start asking the question that, Kumar, can we validate? Can we take it up and intervene? Do you want to remove your chemotherapy out of it? Do you want to add later on chemotherapy when the patient has this signal positive? Do you want to start changing those treatment for these patients when you see these curves like this? So upper one will say, hey, can you de-intensify? You give TKI plus chemotherapy. Lower one will say, hey, do you want to add something, either chemotherapy or something else beyond what you have been giving? So yes, it was striking. Now, does it mean that it is striking every time? No. So what we did for the resistant mutation, that was the first sample which was done. So what they did, and whole lot of credit to Atul, he said he did resistant anytime. And it makes sense that if you pick up any time, that doesn't divide patients so well. If you pick up early, that time it divides patients well. Looks like as it goes by, anyway, natural resistance is happening. If natural resistance is happening, that is not dividing the group of patients, is strikingly different. But if they are there at the time, at the first sample, and then you're giving treatment, it is not selecting because of the treatment, and it appears they are dividing the patient strikingly different, which we saw it here. And again, Raja sir, he will say, Kumar, this is not which I like to take in the clinic. These are dividing patient well, not enough to that you will say that I'm going to change treatment, I'm going to intervene treatment. Say, upper curve also requires intensification. As far as this data is concerned. But this data is striking, and this data looks that you need to take this further, investigate more to see that how we are going to change treatment in these group of patients. And if we can do some more samples in one other cohort, they say, hey, prognosticate those patients. There's a tumor fraction decides. So Atul did lots of ROC curve, because this is the way you do when you have so many samples, you try to get some numbers, and then he used the cutoff and tries to, does the tumor fraction decides that who will do good or bad at the first sample? It looks like yes, this is also something striking. Now, I don't know, Atul, how you're going to combine will be useful. If you can combine this part and this part, let's see what we get. At this moment, we don't have, but looks like tumor fraction at the baseline, again, gives something interesting. Now, what happens to responder versus non-responder and how they behave as the time goes by? Do you monitor it? So question that, do you monitor them? Today, we don't. It does look that responder, you have ctDNA load keeps going down, and in non-responder, as I suggested, we defined it beforehand. It looks like it goes up, suggesting that it gives you a hint. Someone can question, CT scan give you the same hint. I totally agree. That's why one has to compare with the CT scan, and you have to make them fight with the CT scan to say, hey, I do a better job. There are decent data suggesting looks like they do a better job, but doesn't look like they do a strikingly better job. So they pick up 5 months early. That's good. Can we pick up far earlier and then intervene? That does not happen. But looks concept-wise, what we are getting earlier gets validated here that your test is working well. What happens to VAF? Same responder, non-responder. Looks like yes, the VAF keeps decreasing if you have a responder. It doesn't decrease if it's not responder. Then Atul was keen that we have this case, one case and how it looks like. And what you can see here, in this case, it appears the moment the patient had the resistant mechanism, you had peak in the what we have, the resistance mechanism which happens to this individual patient. And this is for responder. It keeps going down, and you don't see those resistance mechanism coming up and the VAF going up for those resistance mechanism. We have data regarding HRD and TMB. They are good. They are not so striking. It gives some meaningful result, but I'm sure we need to work more on that to see that how we can make it clinically meaningful. But what it is important for me that TMB in liquid biopsy is a challenge. So it looks, Atul, you have cracked things well, because TMB today is a biomarker, not the most important one, but many people like to know. HRD is an important one. And if we can do in liquid biopsy, it is useful. So that way it looks that, yes, there's a possibility that we can have, and one can do it for our patients. So in conclusion, if you have the resistance signature at the baseline and the first sample, it is important, and it divides patient well in doing good versus bad. Many other things divides it. We need to see how we can combine it, and monitoring part looks useful, but how to make it clinically useful, that is something we need to work on. So with this, I say thank you so much. We'll be happy to take questions, or we'll have a panel. Thank you so much. So all of them, especially, yes, you can see this person, Atul, he works very hard and really did a wonderful job and had all answers to it, because there was a lot of to and fro. What do you mean? Why it is there? How it is coming down? What you're seeing? And I need to acknowledge that this group, and especially Atul, had all the answers to whatever questions was thrown to them regarding this data interpretation and the clinical aspect and correlation to it. So thank you so much. Thank you so much.
Was it seen that patients who had high tumor fraction, they were the ones who developed early resistance?
So that's why I say that is not the correlation has been done. I wish it was done, and that's why while speaking, I said we need to combine these to see what happens to them.
Question is whether common sense prevails or doesn't prevail. Common sense says if you've got a high tumor burden, you've got a large tumor volume, the response should be less. But in chemotherapy, they say that if it's chemotherapy, the response will be better if there's a high tumor volume, right? So that's the question, whether NGS can answer that question or not.
So this is not only here, the high tumor burden and the outcome. There are a whole lot of data in many other tumors. So there is a merit to that. If you have a ctDNA positivity of patients are, or if there are more VAF is there, outcome is inferior, especially if it is at the baseline as compared to if it is not. Data is there in lung cancer. There is data in head and neck cancer. Breast, colorectal. Yesterday I heard, I don't deal with colorectal cancer. I think so. Breast cancer I don't deal, but I think so. Data is there for that also. So it's not something extraordinary. That's something totally new came up. But this is true that in Indian context, this is the first time. I have not seen this kind of data from India. So it is fairly well known. But having said that, yes, it is validates. Atul, am I making a right statement? Yeah, that there's a fair amount of data, what I understand, that is there. There are many ways, baseline, post-surgery, post-chemoradiation, many places people have tried to do. Yes, go ahead. Thank you. Thank you.
I have one question regarding the resistance which is at baseline. Is the whatever 4, 5 or B2 or 3, that is the only resistance you have seen, or is there, apart from those 5, there are multiple other genes?
So they have 1,000 genes.
Oh yes. So why selected only this 4, 5?
Which is known for EGFR.
Which is known for.
So it is 16.
Okay.
It is not 4, 5 group, I said.
Yes.
But those are 16 different,
16
different genes where the mutations there. And we have many mutations. Like ERBB, you can have many mutations.
Yes.
So 16 genes,
So
but they club together.
Yeah, the club together, the main family.
Making 4 groups.
Yeah, okay.
They're coming up with newer, this is like 12G has come up for KRAS, then there are HER2 news. So there are many things coming up over a period of time. It's just a question of who discovers what. Thank you, Dr. Prabhash.
Thank you. Thank you.
May I now invite Dr. T. Raja, who's going to give his diktat on from bench to bedside, liquid biopsy, real-world evidence in oncology. Also, may I also invite the panel so that he can club his talk with the panel and then take it from there. So amongst the panelists are Dr. Ashish Joshi from Mumbai, Dr. Vijay Patil from Mumbai, Dr. Advaita Gore from Mumbai, Dr. Kshitij Damodia from Ahmedabad, Dr. Nirmal Raut from Mumbai, Dr. Vaibhav Chaudhary from Mumbai, Dr. Bhushan Nemade from Nashik, Dr. Shivashish Bhattacharya from Imphal, and Dr. Sai Vivek from Bangalore. Dr. Raja. You know Dr. Raja, don't you? Does anybody not know Dr. Raja? He's the director of the program of medical oncology, hematology at the Apollo Main Center in Chennai. And he's one of the most dynamic young oncologists. Well, do I call you young now?
Yes, sir.
Okay.
Please, sir. Please, sir.
And has done a lot of work and is very well known in both in the national and international space. Dr. Raja, please.
Sir, thank you, sir, Dr. Rakesh, sir, for sharing this and for those kind words. We've all looked up to you ever since I practiced. Learned a lot from you, from the way you handle patients, and my salute to you, sir. And thank you, OneCell, for putting me here, and amazing panel that you have provided. Wonderful opportunity. Thank you so much. And thanks for allowing us to talk about our own real-world experience that I have worked with OneCell Diagnostics. I'm thankful to them. And amazing talk by Dr. Kumar Prabhash. And amazing talk. Dr. Kumar in his talk said that he doesn't catch a rocket to his home. That's what he said. If he was here, I would have told that he is already flying in the rocket. And all of us, some of us, at least me, when I started I finished my entire college, medical, everything on a bicycle. I brought my first two-wheeler after I finished my post-graduation, and after I became a consultant 30 years ago, I bought my first cell phone actually. Actually a few years down there. Now you see that two-wheeler, it's not a symbol of any cost. I had to book Bajaj and wait for several years. I know at least some of them may remember. Now you can go into a shop and take a two-wheeler and come home. That was unthinkable some time ago. 10 years, sir? Okay, I was 6 years, 7 years. So I think... Right, sir. But then today, leave alone the economics and social interpretation of it, every rickshaw, every vegetable vendor has a cell phone. And two-wheelers are, every village, everyone, because there is a need for it. The need is the most important thing. So I'm sure whatever Dr. Kumar showed, flying in the rocket, need will convert it into real life. That's what I think, into the clinic. So let's begin whatever clinical work, our own simple clinical experience. This is the first case, and this is a patient. He's a carcinoma left lung, but he presented with nodal and pulmonary secondaries, advanced disease, and 2019. So at that time, he was found to be PD-L1 positive. And then we did a home Oncomine focus assay, which showed EGFR positivity. And this was the EGFR positivity that was detected. G719S and S768. So I'll start with Vijay. 2019 or even today, when you see a patient, a little elderly man, not very old, reasonably fit age group, 60. So what would you do, Dr. Vijay?
I would first discuss this with my molecular scientist. And after that discussion, this, according to my knowledge, seems to be an exon 18 mutation. So I would have had that in, if this was 2019, would have offered afatinib to the patient. I would have discussed the pros and cons for afatinib and would have started the patient on afatinib.
Great, Dr. Vijay. I think you are spot on. This was the 719S is exon 18. What you said is right. But the 768 is exon 20. So that's the, I think you're almost spot on. That's what we saw at that time. Dr. Nirmal, what you would have done in 2019 and today?
I would have started this patient on afatinib.
So you would also put the patient on afatinib at that time. Okay. Dr. Advaita, what would you do?
Yeah, I would agree with both the other panelists that we would start this patient on afatinib if we were in 2019.
Yeah, okay. This patient had quite a volume of disease. So was clinically in some sort of a visceral crisis at that point. So would that change your thought, Dr. Sai? What would you do? 2019.
But now I think with emerging evidence of combining chemo plus EGFR TKIs, I would be tempted to give him some amount of quick response. But TKIs, if they are sensitive, do give that response as fast as chemo also.
Okay. So actually we heard you at that time, we called you, and that's what, based on that, the Tata paper was, we were all so, impressed with Tata paper, and we thought, okay, two reasons why we went that way. One, this was, that time we realized that this was not a common EGFR mutation, uncommon mutation. That was one of the strong points we thought. And the afatinib in 2019 was still a slightly expensive proposition at that time. And we thought that the uncommon mutations were partly answered by the Tata paper. That's what we thought at that time. So I think, so we went that way and put the patient on pemetrexed, carboplatin and gefitinib. That's what we did. The patient responded very well. And then the patient was put on maintenance therapy with pemetrexed and the gefitinib. And 2019...
You added gemcitabine as well.
So no, sir. Gefitinib, sir.
Gem.
Sir, sorry, sir. PemGem is pemetrexed. It's the trade name, sir.
Oh.
Sorry, sir. So pemetrexed, carboplatin and gefitinib. That's what we did, right? So the patient went on to do very well for about, up till 2023, was doing amazingly with this kind of thing. And then the patient progresses. So then, what would you do if the patient had a good run and 2023 you have this?
Yeah, so most likely, even in spite of a typical the mutation, the patient has responded well to the maintenance TK as well as how many months the PEM was given, like for maintenance? Continuous. Oh, continuous. Okay.
Continuous.
Oh. So I would because patient is in 2023, I have an array of investigations. So I will once again go ahead and do a comprehensive profiling genomic.
Yeah, we can ask. That's an interesting question. We can ask Dr. Siddhij also. And then we can come back to Vijay. At some point, can we drop any of these things when we go on very well? So we'll come to that because their group may have an insight on it. Actually.
So, sir, on progression, definitely we would like to see the molecular profiling by a comprehensive assay in 2023. Yeah. And regarding the question whether initially if I encounter a mutation like exon 18 plus exon 20 insertion, I think chemotherapy would be my first choice to give.
Yeah. I agree. That was one of those reasons we got a bit attracted towards chemotherapy. And but Advaita, would you want to drop, if the patient is doing so well, if at all you had used this Tata regimen and they respond very well, and then you continue, would you want to drop any of that along the way? And is it, how did their experience go? What do you know about that actually?
If the patient has been doing well with the chemo plus an EGFR TKI combination, we know that the initial induction kind of regimen was using a carboplatin plus chemotherapy doublet with geftinib, and pemetrexed maintenance I use in practice along with the EGFR inhibitors until disease progression. The toxicity is quite limited. We know that pemetrexed given over a longer period of time does not really cause too much of problems.
No, I agree. So my question was,
I would not really drop
this combination of pemetrexed maintenance plus gefitinib, how long the tolerance goes? That was what I was trying to.
We had incidents in the study of renal dysfunctions coming in patients with who received pemetrexed for long. In fact, we have planned another study in which when we had data which was for ctDNA data, which was not shown today, we had seen that in those patients the drop of ctDNA was to a huge proportion, but it was not detected at 2 months. They did very well. So the next study which has been planned is actually you start with geftinib and pem-carbo at 2 months. If that it is not seen, then one arm will continue with geftinib pem-carbo. One arm you might just drop pemetrexed. That's the
You want to drop the pemetrexed?
Yeah, you want to drop the pem. That's the next study which would give an answer. But this is in those patients in which
ctDNA drops.
Yeah.
So let me say what happens, and I'll come to you. So this patient progressed in systemic disease, neuroparenchymal disease. So we talked to the patient. The patient was not willing for any further chemotherapy or anything. So what we did, we just gave RT to brain, and we started the patient, convinced them on afatinib, and then we did a repeat biopsy. But then actually he had a very rough time with afatinib, only 1 month, couldn't tolerate at all. So that's what happened. So repeat biopsy was done. I'll show you the repeat biopsy report. So this is the chronological summary of what happened to the patient. So don't ask me why afatinib. So we might have discussed osimertinib and all, but I'm waiting for the biopsy, and the patient is anyway not affording. All the discussion happened. This is what happened actually. So then this is the scan that you can see that the one on the left is the latest one, progressed, and that's where you can see the progression, and the biopsies are all done. Neurological progression, everything is there. So now this is when we have the comprehensive genomic profiling, and this is the profiling here. You see that the EGFR G719S is still there with a VAF of 30, and S768 is still there with a VAF of 27, and you see that this has picked up a T790 with a VAF of 27%. And you also see that there is an FGF19 amplification and the GAP2 amplification, 6 copies each. And then you also see something interesting down there. HRD, according to the lab, was very high at 52%. And the PDL1 was positive, originally was also positive at, this is the report that has come, okay? So now with that, so what would you do? And the patient has developed a new T790, at least detectable now. So what would you do?
I would actually go for osimertinib at this point of time. But yeah, cost constraints are there, as you said. So that is a more logical and rational choice. But where actually you have already done radiation to the brain, that part is temporarily taken care of. So some non-affordable patient may actually re-challenge with Abraxane carbo 3 weeks out of 4. That might give a good symptomatic response as well. But for long run, I think osimertinib should be good.
Okay. So now, one thing that's important is go back and talk to the molecular team, the molecular tumor board. So let's say we did that. And this is the take from the molecular tumor board. So what does the molecular tumor board tell? It says that, look, you've got a double EGFR, fine. And then you've got a T790. That much we all now can interpret. But then they tell me, look, you've got an FGF19 and amplification. And these two tell that there is a bifaceted activation of the tyrosine kinase. And therefore, we anticipate that there will be an osimertinib resistance. That's the input. So very valid, it has come. And then they also say that they go one step high, saying that broad spectrum selective TKI, lenvatinib, may be effective, and there is a CPS of 5. Now you are in a 2-line, 3rd-line setting. Think about that. Lenvatinib, pembrolizumab, they suggest, and they also add a one note finally saying that HRD is high, and would you want to consider Psi? So you get all these info. The whole idea is to talk to the mall team. We have done that. You got all these things, and based on, so what will you do now?
I think I would take their recommendation that they might be osimertinib resistance at this point, but at this point with brain metastasis treated, I wouldn't actually worry about chemotherapy right now, but I might actually discuss with the patient about use of a multi-tyrosine kinase inhibitor and keep osimertinib aside just because of the financial toxicity and the lack of benefit as per my discussion with the molecular team. But I would be very skeptical about adding immunotherapy at this point.
Okay. Sir, so in your settings, sir, when you have crossed 1 or 2 line EGFR directed therapy, what do you do, sir? Just forget about all these things. Just practically, what will you do? And then if you can.
Practically speaking, comprehensive genome profiling is not as available in peripheral parts of India, and it's a new thing. You could do it because in a big city. So normally what happens, what was the standard practice, that once patient fails in 1st or 2nd line, nowadays many people use erlotinib also 1st line. And so we go for T790 mutation from the cell-free DNA because it comes as a companion testing. They do it not by NGS, by simpler techniques, RT-PCR. That is the usual practice. And they give the report as a companion testing, and if you find it positive, go for osimertinib. But now with the CGP, you get more insight, and this selection which was correct in a setting may not be correct 2 days. And patient will show up that patient is actually progressing, will not respond to osimertinib and will progress clinically. So you know that osimertinib is going to fail. And incidentally, I could practice in a country where osimertinib was 10,000 BDT, means 7,000 Indian rupees. So for 2 years, I forgot using gefitinib and erlotinib. So all my EGFR patient used to get osimertinib, and I did not know what to do after failure of osimertinib. And that osimertinib also works, not that due to 10,000 that doesn't work. Some patient achieve complete remission as well, and some patient progressed that well. So it takes you to the different.
Great. So, you have better not talk to the molecular biologist, but you have talked. You got a threat of osimertinib. You have a T790 mutation hanging. So what will you do?
Yeah, I said actually T790 is there, so there is data that osimertinib works. Data regarding this, obviously it's always have to have good insights from your molecular biology team. But in the end, you are responsible for the patient. If something goes wrong, then you will be sued, not this test or not AI. So the thing is, I would, depending on tumor burden, if tumor burden is there, I will be tempted for a short course of chemotherapy.
Nirmal, what will you do?
So I don't mind adding a multi-tyrosine kinase inhibitor here, because that FGFR is also amplified. So maybe osimertinib plus lenvatinib.
Osimertinib plus lenvatinib? Yeah, I think amazing. You have always been the upfront to add this.
Molecular input is not yet incorporated in any guideline.
Very true, sir. Very true, sir.
If it is the insurer, they will not approve even my lenvatinib. But osimertinib will.
Sir, insurance is a difficult topic.
That's what I'm telling.
Guideline is acceptable, agreed. But my only humble submission is that
guideline they will not approve.
But again, sir, we have crossed 2 lines. 3rd line afterwards, I think normally you enter no man land, and no data land is always you enter. So then, of course, I've heard both of them. So what we did is, of course, we spoke to the patient. What else can we do? We started the patient on osimertinib. Now he is ready. He doesn't. I'll come to you. Definitely, Vijay. But we have offered them whether you can consider pembrolizumab. That's what. This is August now. The patient is still taking osimertinib, still holding on well. Now we have actually crossed, coming to the November. That's what is really happening. Vijay.
I wanted to ask, when you have such kind of FGFR resistance, this patient I thought progressed in brain also. Would have given a thought to the Bloom-like regimen? You would consider giving osimertinib 160 mg?
Brilliant. Yes. Why not? Yeah, that's a great thought. But we had, I totally agree. In few patients, I have now offered and put patients on high dose osimertinib. Totally agreed. But this patient, I had to convince him to take osimertinib, and he had a very bad experience of afatinib. He does not want any more chemotherapy. He is very clear. Son is very insisting, but he is very level-headed man. So he is on osimertinib. Son says that, sir, whenever my father always says no, but whenever you need, I am ready for pembrolizumab. That's where it stands. But we are in November. Actually, he's doing well, to my surprise. For all the, like what he said, I think you listen to the molecular biologists. No, don't worry about the swing, but make your own decision is what you said. I agree with that. So another second patient. Now, this patient had... Sir.
What about amivantanab? I know it's not available or whatever, but if you had
Sir,
possible...
totally agreed, sir. I have patients on second line amivantamab, and I have patients on first line amivantamab I showed yesterday, sir. That's true, sir. But this patient was not willing to take any IV, anything, so... And whatever happened to the patient, I'm presenting it.
Sir, the previous patient, he had T790M with exon 18 and exon 20 insertion
Still
mutations.
persisting, yeah.
Yeah. So I don't know, osimertinib, the activity in exon 18 and 20 insertion is not that good. So perhaps, what about giving a thought about IO plus VEGF plus chemotherapy, ABCP regimen?
Okay. To answer your question, we have had patients whom uncommon EGFR mutations treated. And in fact, I have patients, uncommon EGFR mutations on afatinib, and then they progressed to develop T7. I have such patients. And then the trouble was to finding data, how do you treat patients post-afatinib? But there was actually a real-world series on post-afatinib. So those patients, when they emerge T790, put on osimertinib, respond beautifully, and then they go back to remission. And in fact, their original clone comes back. We have all those experience. The data is also there.
In fact, there is a unicorn study also for osimertinib to be used in uncommon mutation. And in fact,
and if they develop the, what do you call that, escape mechanisms, you are absolutely well within right use. So second patient.
I had a question for you.
Please.
So post osimertinib failure, how comfortable are you using only single agent amivantanab when lazertinib is not available?
I have patient on single agent post osimertinib failure. I have patient on single agent amivantamab showing excellent response, having a good PFS. I have that. Lazertinib is not available. So if and when it is available, I will seriously look at the ESMO paper, and then we are itching to get it, but not yet. Maybe you can get ahead of us, actually. So the second patient, the different patient, peritoneal carcinomatosis.
Question about 160 milligrams of osimertinib. It's not easy to tolerate.
That's true, sir, but in a specific setting, CNS, particularly CSF positive disease, CSF, we have...
Tolerance is not easy.
So we have patients who are able to tolerate, sir. It's okay, sir. They are tolerating, sir. I have specifically used in...
Very bad experience with 160.
In fact, frankly, I find the tolerance to high dose osimertinib is much better than 40 mg afatinib.
I completely agree. Completely agree. So second patient... This is a different patient. This is a peritoneal carcinomatosis, extensive disease, peritoneal carcinomatosis. And it's still qualified as a poorly differentiated carcinoma, probably from GI, pancreaticobiliary, peritoneal carcinomatosis. We did a HER2 negative, and this is the histopathology, laparoscopy, peritoneal biopsies, and our very aggressive surgeons would do pipe pack also there. but it's an open and closure, multiple biopsies, pathology. If you are very interested about the IHC, everything is there. This is a picture. You can see loaded disease. I mean, this also in August 2023. Okay, so what do? Desperate, do a CGP. So we have the CGP. This is the CGP. So you have a tier 2 finding TP53, but with a VAF of 86%. And then you have a CCND1 amplification of 5 copies. And you have stack 2. And you have a PDL1 negative. This is the finding. So to help us all out, we immediately call the molecular biologists for this, because it's not like EGFR where you want to look confident, but you are straight away, you know that this is a bouncer, you better call them. So what they say is this. They say that this is a pathogenic alteration detected with both tissue and ctDNA. So we did both biopsy, and ctDNA was complementary done, TP53 and stack2. And CCND1 amplification is also important as far as they are concerned. So both in tissue and not in plasma. So TMB is significantly higher in the ctDNA. So they say that aggressiveness, higher metastatic potentials and all that. And they say that we have a CCND1 amplification, consider checkpoint inhibitors, and they even tempt me saying that why don't you consider CDK4/6 inhibitors and all that one. Okay. And definitely they would send these references to validate their thought process. Fair enough. So now what will we do? We'll begin with Nirmal. So this is not a common thing, uncommon, difficult case. So what do? We have some funny markers.
So the tumor mutational burden is high, so I would try checkpoint inhibitors, and along with that CDK4/6 inhibitors also can be tried.
This is first line setting.
First line setting.
I'll go with chemotherapy.
Okay. So what would you do?
I would have started on the chemotherapy, and I would have searched for a literature what it really means. But definitely I would have started on the chemotherapy.
So what we did, again, like what he said, I'm listening to the molecular, making my own decisions. We did that. Actually, the patient is getting better. 5th cycle gone, 6th cycle. But I'm listening to them. I'm keeping my eyes open. If the patient progresses soon, I will be in trouble. So that's
so why FOLFIRINOX? Like it is
aggressive.
A
Young man. Did I say that? It's a very young man. He's only 38, loaded disease, and his wife is a doctor, but that does not mean anything. Very young, fit. If you look at him everywhere else, but if you open the abdomen, it's just like a rock. I showed the picture. Very aggressive disease, and this is the patient. I think triplet, bevacizumab, you throw everything. If at all I want to go the chemo way, I get him everything. That's what That's what I've done. And actually, he's responding. He's responding symptomatically. Is very, very better. He's already crossed 5th cycle. I think he may be soon coming into the 6th cycle. So, sir.
All patients of poorly differentiated carcinomas, one of the messages is that you should do an NGS in that group of patients. Do you agree with me?
Yeah, definitely, sir. Particularly in unknown primary, you better think about this. Difficult cases, you better do it early. CGP will help you. And look at what Kumar showed. They are able to look at the variant detection and resistant dynamics. I think the world is changing, sir. We need to do everything. I agree.
The VAF for P53 was, I think, 86%. Wanted to...
Chirantan, what would you... That's a very astronomical VAF of P53. So what do we infer from that? Does that mean that I have to do a germline? Both were... I mean, you said ctDNA, both are positive. Can you...
Ma'am, actually, there are both the things. So... if the VAF is around 50%, because the autosomal dominant characteristic, then we know for certain that this is a germline. But this high VAF, sometimes there is biallelic somatic mutation or loss. So then we need to do a germline testing to establish. So it just doesn't 90%, 95% just doesn't directly establish that it is germline.
So when we...
Correct. So these two factors of
Tumor
this,
fraction in the blood, that's what she says. This is both tissue and blood. I know. So,
sir, even in the tissue, because when we do the extraction of the DNA, it has got like the mesenchymal, mesothelial cells and other stromal elements. So if high tumor fraction or biallelic mutations will all lead to this kind of a very high.
I agree, Chirantan. I think I took her question that if in the blood we see the tumor fractions to be high,
Yes, sir.
and will that be impinging on our VAF interpretation? That's what I'm taking her question to.
Such high, very high, starkly high.
Okay. So another case. This is a head and neck malignancy. You see, it's a middle-aged lady, very fit person, goes through the basics, gets a surgery done, T4N2, and then surgery done, and then concurrent CTRT, conventional disease progression. So what will we do? At that point, the patient was put on cetuximab plus chemotherapy. Again, had a decent PFS on that. That was from 2020 to 21, and then has another progression in May 2022. At that point, a PDL1 was done. PDL1 was positive on the tissue, so the patient was put on immunotherapy with cis-5FU pembrolizumab, and again has a somewhat 6-7 months of PFS, but has again progression here. So then we put the patient on, as the patient has progressed, we have already exposed, concurrent CTRT, and then cetuximab chemo, and then again with pembrolizumab chemo. He was not willing to take any more chemo, so we had put her on nivolumab and cetuximab. Again, she did well with that. That was just after that ASCO presentation of that doublet. Again, she did well, another 6-8 months. Now, in August 2023, she has relapsed. So this is the story. And that's the long story of whatever has been done. But this patient, this is the August 2023 pictures. You can see that she has progressed in the primary site and also in the lung site. And she received some palliative RT in between for that lung lesion that was little painful, and all that done has come with a second recurrence post CTRT, and then this is also RT'd, now come after 2 years plus, like this. Both primary site and lung sites have progressed. So that's what is the situation, and that's the NGS that we have. Again, this patient has this CGP done. And the original NGS on the tissue, on the first relapse, it didn't show anything. This is a blood test, and this shows a RAD 51, VAF of only 1%, and has got a HRD of 62%, and TMB is 9. That's what we have. So very important. I go back to the molecular team, and this is their interpretation. They tell me that deep sequencing, liquid biopsy based ctDNA, pathogenic mutation in RAD51 gene, RAD51C, and immunotherapy markers are negative. HRD score is 62%. Their laboratory cutoff is 50% with a high LOH also, and therefore effective therapeutic option could be that consider olaparib because of the HRD score. This is the message that you get from them. So I'll come back to Vijay in this one. So Vijay is the boss of head and neck. Tell us what to do, Vijay.
I would have given metronomic.
You would have done metronomic. Okay, fine. So then what would you do?
Only these options needs to be discussed only after exhausting all the standard options. I think methotrexate, the patient is not exposed to that. I think first we will be giving that. Still, if you are lacking in options, then we can think something out of the box. Use this as a, I don't know whether we can tell it as an agnostic marker or not. Just like we mentioned MSI, TMB, HRD, to be used in all malignancies, these PARP inhibitors, but only after exhausting the standard options.
Okay. what would you do, sir?
I would have either offer a methotrexate single agent or gefitinib or afatinib.
Yeah,
for the
and,
patient.
totally
Yeah.
agreed. The Tata protocol.
And the olaparib data, there is a phase 2 study,
Phase
I
one.
think. Yeah,
Phase
phase 1
one and
with
phase
the
two,
RT
just those
and
findings.
yes. So
Somebody
but-
wants to look at the toxicity profile. So this is what it is. So, but what in such patient, he has talked about metronomic therapy. I'll tell you what happened. We speak to the patient. Patient says absolutely no for any further chemotherapy. Doctor, I won't even come if you talk. So what do we do? Really, I mean, very, very well knowledge, very balanced, and I rarely go to patient's house. I refuse to do that. But sometimes, even if but the good people sometimes. So she gave great family, great lunch, and so I have to now think something for them. So, so what would you think?
I've gone for a dinner and given her a methotrexate at the home.
She is willing to give you good dinner, but she is still not willing to take the methotrexate. Okay. So now I'll bring another dynamic into this. This patient, from the beginning, we were also doing the CTC. Okay. You see the beautiful. The originally CTRT done, October 21, the CTC were negative. It was quite fine. And February 21, we saw the first CTC to be positive. Patient was still fine. Scans were normal. Sorry, February 22. May 22, the patient has a relapse. The CTC has doubled. So, it was to act on CTC was like, no, we can't do all that. And none of the leaders have done it. So what do we do? But then from May 22 onwards, we have been doing something that has kept the CTC down. So we'll come to CTC in a bit, but this is what happened to that patient. So just interesting thing. So what we have done is we had put her on, proton therapy for both the primary site and because they were still limited, re-radiation 2 years down the line. It's something like, only a oligo kind of a thought. We have done it. She has finished proton and then she has got a terrible facial cellulitis, but that's resolving. Diabetes mellitus is being managed. But now we need to think, what do we do for her next? We are waiting in the wings to see what we can do. Again, the proton was completed just about 20 days ago. She has gone home. So another patient. This patient is even more, 70-year-old gentleman, very, very successful businessman. And he has been watching a liver lesion growing from 2021, liver SOL. We don't know whether it's malignant or not. Diabetes mellitus, hypertension, coronary artery disease, 3 stents, CKD, and has got a stage 4 muscular dystrophy. He's on a wheelchair, but really indomitable, absolutely bright thinking and spirits gentleman, and a very dedicated family. So the tumor looks like, as it has gone, looks like HCC is what the radiologist would want to tell you. Okay. And look at this. Look at that jutting out lesion like that. Very large lesion. And one more picture here. Look at that. It's really standing out of the liver. And that's what. It looks like a single large lesion with a heterogeneous thing, and you see a central necrosis and all that one. Our radiologist will go on to describe the whole thing, and he says that this is abutting everywhere, but it's not infiltrating, but there is heterogeneous, central hypodense and all that. One more picture if you want. This is the fragility of the gentleman. 70-year wheelchair bound, very, very high spirit, very intelligent, bones compressed due to osteoporosis, whatever. That's the lesion. The trouble is that I have to prove what it is. The disease has been growing some more part of the history. He knew about this kind of a liver lesion way from 2021, and very, very eminent gastros and big teams have been seeing. Once one FNAC was attended 2021, it was called as an adenoma. At that time, it was very small, kept in observation, ultrasounds, scans, AFP, CA19-9, everything is negative. We have come to again August 2023. All cases are all August 2023 time point I'm presenting. So this is a large mass, and it has grown to this, but it is just like a pumpkin that has grown. The trouble is whether to biopsy or not. The trouble is, if you then there is a real risk of.
I have a point.
Yes, sir.
Issue here is, did the triphasic CT was done and the typical character?
Everything, sir. I have got. I only put
typical character of HCC was there or not?
Yeah, the trouble is, sir, nobody's, MRI is there, PET is there, and we have a 640 slice CT, everything is there. So this
But
is where.
the description was never as arterial enhancement and washout.
Yes, sir. This is what is the description. This is the 640 is the last, description, and radiologists would want to say this, that this is a neoplastic mass and with probable spread. That was post MRI, but the 640 didn't see that adjacent peritoneum. So this is exactly what was there in the clinic. And even now, let me say, I only have the radiology, and so we think about two things: biopsy and surgery. Yes, sir.
For HCC nowadays they do a test. I forget the name. The gastroenterologists do it. If it is positive, then they don't need a liver biopsy.
So
PIVK1, that is also there.
Sir, we have it in our hospital. We routinely do it, sir. It's a negative. So those are all routinely.
But there are non-secretors as well.
Absolutely, sir. AFP is negative.
Is there any evidence of CLD here? Any viral markers? Any CLD?
Negative.
Third thing is the chromogranin A being done?
Chromogranin is negative, sir. So we have thoroughly worked him up. So fibroscan, there is no CLD there. Nothing.
So you ruled out NET, you ruled out CLD, you ruled out viral.
Yes.
So,
Yeah.
And you said the marker for
Negative. Yeah. So now, the trouble is, do I do a biopsy? And if I don't do a biopsy, whether there is a high risk of spontaneous rupture, and if it bleeds, in big trouble, surgery, and also surgery. So for surgery, he's a very eminent man, so we take opinions. You go to the surgeon, and he's a muscle dystrophy man, CKD, and they say that you have 25 to 30% chance of worsening CKD and ending up on dialysis. He says that he and his wife say that we don't want that. We don't want that. I have lived a great life, doctor. I've done everything, this and that, which is true. He says, I don't want. So then I send him to a second opinion. I've sent him to one of the most eminent liver transplant surgeon in the country, Dr. Rela. So he had seen, our surgeons, everybody has seen. But all of them said that, yes, we can try, we can resect this, resectable, but 30% chance of getting into a full-fledged CKD dependent on. Now, resection, after resection, if it still turns out to be an adenoma and then he is on a dialysis, he asked this question, that's not an acceptable parameter for him. He says, I can't take that. So now what do? I can't biopsy, I can't do anything. Okay, so what is the rate of growth of this? Sir, I have shown from 2021, it has grown in 2 to 3 years. From small, it has really grown, sir. And it is now, it's really this, sir. Anytime, even if he hits somewhere inadvertently, that's going to break. That's my real worry. Likely HCC. That's the best closest they can come. Okay. So anyway, then what do? We do a liquid biopsy. Telling them that liquid biopsy is substitute for solid biopsy. We do that. You tell me, I've got the liquid biopsy.
Because there is another deposit apart from the liver.
No, we have ruled it out. We got the MRI done. We have ruled it out. The 640, the peritoneum is gone. Okay. This is the only pumpkin. Okay. Touch it or with risk or live. Okay. He twice got admitted for surgery. On the day of surgery, he will refuse and go back. Actually. So that really happened. Actually, okay. Really, I'm not exaggerating. So this is the liquid biopsy. So now you have the liquid biopsy, TP53, NF2, and so on. And look at something they have written there, CTC 1.5 ml clusters. Okay. So they say that upon deep sequencing, circulating tumor DNA and pathogenic mutation TP53, NF2, TMB borderline, and they go on to tell me that put the patient on mTAR and MEK inhibition, trametinib, etc. And sir, yes, exactly. And they are also, keen to educate me by sending all these things and making our life more difficult. Nirmal, what will I do? I don't have a biopsy. 71-year-old gentleman, a very nice gentleman, very knowledgeable. Okay, I did the same thing. I was really thinking. Okay, I didn't know what to do. Multiple counseling. Each time you think you are a very good counselor, you just have to sit and counsel him. Then you go back thinking that, no, I have to relearn counseling. He beats you. So this is the blood NGS. So this is the point. Now, that's the CTC and the CTC of 4. It is qualified, and then they will say that the CTC is not just, it's a cluster. So they call very excited, doctor, there is a cluster. Absolutely, this is significant. 2 CTC clusters. We don't see that very often, CTC clusters. So then, here is the, circulating tumor cells. I don't have to educate this audience on what is circulating tumor cell. But this is where, the OneCell diagnostics, they are really pushing the boundaries. They are really into rocket science now. And this is what is their technology to detect the circulating tumor cells. And, they have, I've been fortunate to be, 1 or 2 wonderful experience with them. Here they are able to detect. So I'll turn to Gowhar. How are you, what is this technology? How is that you are capturing that? You can tell, and where is
I
Jayant?
think Dr. Jayant is the right person
Where
for
is
this.
Jayant? Oh, is he sitting? Sorry, Jayant.
Yeah, I'm here very much. Thank you. I think the clusters, they are more aggressive, and especially I think this is a rare case where options are actually exhausted. And good that I think patient has been able to have clusters. I don't think so in the world anyone actually defines sensitivity, specificity as great as actually this along with the clusters. So we are very confident that this patient has progressive disease, and probably you might have to take a decision beyond guidelines and whatever your practice. Yeah. So
can you distinguish low-grade tumors from HCC? That's what he's asking.
Yeah, see, presence of one CTC with a cluster is associated with worst outcome. But in this case, the situation itself is so systemic, disease progressive.
If at all, possibly. Yes, sir. If at all it is. It is shedding. So obviously, sir. So,
yes.
So this is a lot of things about minimal residual disease and clusters. And this is a wonderful paper that Chirantan sent across, lingering mysteries. If you detect CTC, your lag time to detect the PET CT scan is 8 to 36 months. So with this knowledge, are we okay to act on this? So what will you do? What will you do? Are we ready to act on this in the clinic?
For CTC as a
Yeah.
routine follow-up?
Yeah,
I
given
do
situation-
it for a few indications, not for all malignancies.
For example, he asked me, doctor, if you're really sure that this malignancy, then I will take the risk and go and get operated. So that's the single question I have to answer.
So for the previous patient, definitely.
This patient only.
Oh, definitely patient has a
what I'm
malignancy.
showing is all in that patient.
So in a documented malignancy,
it's not documented.
No. In documented malignancy, CTCs are rare. In this patient, there are clusters seen. So I am sure we are dealing with the malignancy.
What will you do? The patient is
treatment wise.
No. I'm asking our next panelist. Given the patient, I have to take only one call that's saying that this is malignancy, get operated. If I am confidently saying he is going to get radio operated, but if it comes back as adenoma, then, and if he gets into a CKD, then that's a nightmare. And so in that situation, the laboratory has come to your help. Will you act on it? That's what I'm asking.
So,
yes or no?
So see, obviously yes. Malignancy, yes. Number one. Number two, surgery. I think the risks are too much in this patient, CKD and all those things. So no to surgery. Now what to do? We are left with options like we consider as just probable HCC, something like that. start him on HCC treatment and see whether the
So
patient
you
is
are
doing
even ready
well
to
or
offer
not.
systemic therapy. Advaita,
I mean,
would you act on that report?
I would not act on the report.
Okay.
I would still discuss this with the patient, saying that look, these CTCs are positive. It's highly
have
probable
done
that
that.
this is malignant, and if at all any treatment, then take the risk and go for surgery would be what I would offer this patient.
I did the same thing, Vijay.
CTC clusters are seen, sir. I would actually tell the patient go ahead and do surgery.
Go ahead. Nirmal? Surgery.
Same surgery because whatever target therapy or whatever if you are thinking on, first of all, we don't have concrete evidence here that this is malignancy. We are thinking about that. So surgery will get the whole specimen and then we will be more better guided to choose the systemic therapy after if it is needed in such a comorbidity.
Sir, would in this
Why don't you say it is a tumor? It is a huge big tumor, and tumor itself can burst and you can die.
we have said, sir, he knows all that.
So you go for surgery,
He
please.
knows all that, sir.
Sir, I have
please go for surgery.
one comment on it. Are we dealing with the localized disease now or a malignant disease? That is what is the question now. If
It
there
is
is visible
localized.
CTC,
It is localized,
No.
resectable, with risk, and all I have to say is malignant or not. That's the word I have to use.
no, it is malignant. I don't have any doubt in
Oh, you don't
that.
have any doubt.
Yeah, so when CTC's clusters are seen, are we supposed to post this patient who has so much of morbidities for surgery where CTC clusters are seen in a peripheral blood?
So you say that with CTC
Yeah,
cluster,
I would not post
you
for
even
surgery because
go ahead
I know
and
that
treat the
patient will
patient
fail.
with something
yes,
else.
if I don't give systemic
Level of
treatment,
evidence of
patient will
CTC, not yet much.
No,
Rakesh sir, what
No guideline.
What is the interpretation of the CTC cells? Everything depends on that.
everything depends on that.
So what stage we are looking at? So are we really looking
No.
at this?
See, you are basing this on a mass in the liver
Yeah.
and CTC positive. That's what are these cells? Can you say they are malignant or not?
So when we got this sample, we got it for both CTC and ctDNA, right? The CTC test gets done quickly. The only question to us was, what do we see and what do we interpret based on our experience
Sure.
of close to 5,000 patient sample.
Yeah.
This is probably the rarest of rare case that we have seen, where we are seeing multiple clusters, multiple cells appearing having PDL1. For me, this is a sign of high aggression of this cancer. Circulating tumor clusters have the great ability to evade the bloodstream. They have 100 times more colonization potential than a normal CTC. So what literature tells us is that this is a very highly aggressive form of cancer. This usually forms in the hypoxic areas of the tumor. So this is very highly aggressive. So we cannot, of course, talk about, once the molecular report comes.
Can you mark?
We cannot do
Do you think it is a cancer cell? By looking at the CTC.
Sir, we
No,
will,
that-
we
sir,
will
that is-
guarantee that's a cancer cell.
No, that's already agreed, sir, because they have technology to say all these differential markers, they do all that, sir. But my only problem is, am I ready to bet my neck on him? That's the point. But they have all the technology, they brought it up. Anyway, as it stands, when I spoke to Mr. Aravindan that day, the patient was admitted for surgery, but again, he went back home on that day night when we want to put this gate. But I think I will go back and try and convince him. He is still at large. He is still there, and it's going to be a challenge. But anyway, CTC, we looked at various papers on the relevance of CTC in various clinical trials. Whether it has turned into prime time practice is the only question that we are trying to ask here. And of course, there are some trouble with CTC. In some places, it may be, these are theoretical and everybody knows, I don't even have to touch. Concordance of CTC with a scan. And the most important thing is there is a favorable concordance, and the discordance of PET being positive and CTC being negative is the fourth quadrant, that is less than 5% or less than 3%. So that's a great takeaway, confidential and information. Thanks for that.